And what does fibrin do in the wound? Remember how it pulled the wound together? Well, in an adhesion, it will also contract. And if it's around an intestine, maybe that's where it formed its anchor, then you can have an obstructed bowel.
Beyond Clean offers a creative look into the inner workings of a healthcare industry committed to getting it right every instrument, every time. Join us every week as we explore the hidden world of one of the most important aspects of safe surgical care. And now your hosts, Michael Matthews, Hank Balch, and Justin Poulin.
This week on Beyond Clean, we speak with Dr. Wava Truscott, president and founder of Truscott MedSci Associates, LLC. She has authored over 70 articles, co-authored the Microbiological section of the AAMI Sterilization Recommended Practices, and was the U.S. delegate for ISO's medical device Biocompatibility on Systemic Toxicity Testing for the developing European Union. Areas of career emphasis have included the adverse consequences of particle contamination of the surgical wound, unplanned hypothermia during surgery, and the prevention of healthcare-associated infections. Wava has approached HIA reduction as an overall effort including environmental services, sterile processing, infection prevention, nursing staff, physicians, patients, and visitors. And Mike, I'm going to let the cat out of the bag a little bit here, but you have been hoping to bring Wava on and have identified her as a must-interview guest since the first days when you joined Beyond Clean. So I know nobody's more excited than you are to have Dr. Truscott on the episode today.
Yeah, you are absolutely right, and I am very certain that I probably drove you and Hank crazy on more than one occasion. Saying we've got to get Wava Truscott on here. We got to get Wava Truscott on here. And one of the primary reasons is because, especially when I was a new tech, I was kind of constantly bugged by the question of what if what I do doesn't actually matter? What if all this emphasis on education and doing things the right way really doesn't matter, and the autoclave really is just a magical machine that just fixes all of our wrongdoings? How do we know for certain that the little things, really do add up to patient outcomes? And I'm betting that I'm not the only one who's had kind of that nagging question in the back of their mind. And this is the exact interview that's going to answer the question of why behind a lot of the things that are recommended.
Well, there's a thing that happens when poor culture settles in. It's called rationalization. And it's exactly what happens when you get disillusioned. Does it really matter? And hopefully these, starting with today's first segment, but hopefully these two episodes with Dr. Wava Truscott will help prevent people from falling into that trap whenever they find themselves in a difficult culture in sterile processing. So I'm looking forward to it as well. Before we get started, a reminder to everybody, you can subscribe to Beyond Clean on iTunes, Stitcher, and now Google Play and Spotify. And also, simply search for Beyond Clean on your favorite podcast application. You should be able to find us there. We can also be heard on the Sterile Education app. That's available on iTunes and Android as well. You follow Beyond Clean on Twitter at Beyond Clean Info, Facebook.com/Beyond Clean Podcast, LinkedIn.com/company/Beyond Clean, the Instagram page, Beyond Clean Podcast. And if you do want to post a picture anonymously on our Instagram, or if you have a recommendation for a future guest or topic for the show, or just general feedback, send us an email to info@beyondclean.net. We'll be right back with Dr. Wava Truscott. Joining us now is Dr. Wava Truscott of Truscott MedSci Associates, LLC. Wava, thank you very much for coming on the show.
Oh, thank you so much. I appreciate this opportunity very much.
So I'll let you in on a secret. Hank creates the outlines for all of our interviews, and he has a title for segment 1. He says Lint, patient enemy number 1. And I thought we'd start right there, and maybe you could tell us a little bit about what is lint, define it, and how it impacts patient wound healing.
Certainly, I'd be happy to. Lint is more of a general term. We're talking about things that come off of products that are present in the operating room or present in your surgical product, such as an endoscope, that can cause quite a bit of damage within the body. The classic lint comes from reusable, such as cotton, whether it's caps or it's gowns or it's warming blankets or surgical towels. All of these things would have a cellulose-based cotton-type product in it. And cellulose, which comes from plants, is very biologically active. Paper is another good example, a wood pulp product. When you have a lot of absorbable things, it can be paper-based. Doing a central line, they very often use a sterile paper, basically, for the surgical drape. However, when you move a guide wire or you move an instrument or you move a catheter across something that's paper-based, you pick up these lint particles. Or if it comes off of your reusable hat, or cap, rather. These things can get on. They are attracted to plastic. They are attracted to guide wires. They are attracted to anything narrow and slim like that. Staticky clingy, technical term, staticky clingy. And then they can be injected into the bloodstream or for a central line, or they're captured by the catheters. As the catheter is placed over the guide wire, they can track the particles that will then go in with the fluids into the bloodstream. There they can cause a blood clot. In a wound, they can be present, and the white blood cells will come to try to get rid of them. And as they do so, they exude their enzymes because it's too large, so they spit them out, basically, a neutrophil will, and it starts to hurt the healthy tissue around it, causing inflammation. And that lint particle is still not dissolved. And so what it does, it attracts more and more of these inflammatory cells and causes difficulty in swelling with the inflammatory reaction as angiogenesis, which is the creation of the new blood vessels after a surgery. When you had to cut and cauterize some of them, they bud out and start to make new blood vessels. But with the inflammation, it's harder and harder to get to the center, where there's a very hypoxic, which means low oxygen content. And so that remains having a hard time healing. The crusting outer sides may heal faster than the center, and then you can have a poor healing wound where the wound is actually swollen because of the inflammation. The scar is larger, but it's also not as strong. That fibrin has tried to pull the sides of the wounds together, but because of the inflammation and the low oxygen content, you're not getting your collagen in there, which makes that wound not as strong. And you can have dehiscence, which means separation of that surgical wound, whether it's just weak and not as healthy as it could have been, or you actually have this dehiscence or separation, open wound, opening it up for increased chance of infection. And if it's in the bloodstream, you can cause blood clotting. That can end up in the brain. It can end up in your lungs. It has been responsible. Shannon is an excellent author who's gone back historically to find out some of the deaths that she's had and others have had. And found lint in the brain, found lint in the lungs, in the spleen, in the liver. It's just something that we don't look at. If we have a clot, or if we have poor healing, or we have a granuloma or adhesions, we fail to look at it, send it to pathology and says, to say what caused this in the first place. Some have done that. Tinker has done some work on that, as well as several other authors, but not enough to really help people understand how important it is to stay away from lint getting on your instruments or in your wound or in your blood vessels.
The first time I was introduced to what you're talking about was actually a talk that's available online that you gave at the New Orleans, I think it was Louisiana State APIC conference. And you talked about something that I've never heard of before called immune system distraction. Can you explain what that is and why does that matter?
Sure, I'd be glad to. If you have a lint in a position, you activate the immune cells, as we were talking about a little bit earlier, and when that happens and it's unsuccessful in getting rid of the lint particle, it can't do that, so more and more are called in. But that is such a distraction and viewed by the body, if you will, as something that's more important than these one or two bacteria or 20 bacteria that contaminate, let's say, a surgical site. Because there are always bacteria, unfortunately, a few of them, that will enter in that surgical site. But if all the attention is focused towards getting rid of the lint and particulates, then it's unable to immediately grab the organisms, and they have a chance to multiply. The other thing that happens is fibrin is being deposited over there, especially trying to wall off this lint particle. And when that happens, it's like a netting, and the bacteria have an opportunity to get in there and multiply relatively protected by the fibrin, and then form basically a biofilm within the fibrin itself. So the whole immune reaction that should have been devoted to getting rid of the few bacteria easily by the immune cells, those immune cells have been distracted to this larger threat, perceived threat.
So considering this in a context of bioburden, that was my first thought. Okay, we have this immune distraction going on with this lint that's not a type of bacteria, but then it kind of opens the door, I guess, for the bacteria to do more work. Is the same true for bioburden? Is there a distinction, I guess, in just terminology between that and lint? Are they the same level of danger? Because, hearing you describe this immune system distraction, it would make me think that maybe there is a higher danger in these non-organic types of contamination. But I guess, can you kind of speak to those two in tandem, bioburden and lint, comparatively?
I can, and it is interesting because there are a couple of different definitions of bioburden. A microbiologist would use bioburden to refer to the number of organisms when you're figuring out a dose for sterilization, for example. But in reprocessing, different place where we're doing the sterilization and the cleaning, bioburden is actually used to refer to organic debris. And that would be blood, feces, tissues, bone fragments, things like that. So they're kind of used in different areas. So when I'm talking about lint particulates, they normally wouldn't call that bioburden just because it's not organically based in reprocessing, in sterile reprocessing, probably in a hospital environment. However, will they take the time to, or take the opportunity, to actually say, is this organic based? Or is this something that should have been removed during sterile processing? And from that point of view, they may just put it under the same category as bioburden. Does that make sense? It's not well defined as separating organic based versus debris or other things that should have been removed in the first place, maybe lumped together.
Yeah, that's helpful in terms of especially who it is who's defining that on the backside of an event, for instance. It doesn't really matter in that sense, was it organic or was it not? If it's the root cause of the surgical site infection, it should not have been there either way. And
right.
If our process is the point that it should remove anything that's not stainless steel, for instance, and that's the point that the process failed, when it was either bioburden that was not removed or lint that was introduced through the cleaning process.
Correct. That's really how it will be viewed in the reprocessing or sterile processing department.
Well, so a follow-up to that, and I know you mentioned a couple of sources of potential lint in terms of the surgical cap and the paper even, that's used for those central lines. The question that immediately comes to mind, for sterile processing professionals is, well, we're in a department where we've got a lot of potential products maybe that claim to be lint-free, or that would lead us to believe that our environment is not one that has potential lint even available. But is that practical? Is a hospital setting, in a reprocessing setting in particular, is it possible to have a truly lint-free world?
Not lint-free, in definition of the term free being really without any at all. That's just not going to be absolute. However, there are huge differences in levels of lint. For instance, Vircola did a study where either cotton gowns or some paper-based drapes in an operating room, that was their standard. This isn't something just introduced for fun. So this is something they had as standard. They had 850 particles in a cubic meter. When they removed the cotton products and the disposable paper-based products, and then ran the operating room for quite a while because they could continue to have it in the air. And then they replaced those things with the polypropylene, which is made to be low linting, extremely low linting. Then they ended up very low numbers of particulates by switching just those materials. They were also able to find that they reduced their colony forming units, so live bacteria that would be significantly from 45 down to 7. But what was most dramatic is they decreased their sternal, this was a cardiac and vascular surgery center, they reduced their sternal contamination by a huge amount, by 45% of the vascular harvesting of the leg, by 90% of bacterial contamination. Wow. So it really does make a difference if you can reduce the particles that are present in the room, both by them carrying organisms. You can imagine they use it as a transport mechanism, but also just falling into the wound and the bacteria that are free in the air, making it quite a difference.
With that kind of line of reasoning, one of the more common cleaning tools that you'll see in many sterile processing departments is, the ubiquitous pipe cleaner. Obviously, if they're using the classic cotton pipe cleaners, obviously I think that we know the answer to that one on whether or not that would be okay considering what we've learned now from lint. But what about the ones that are supposedly lint-free? Does that still pose a challenge to the patient's healing process?
That answer is going to be a little bit different in that if they are quote-unquote lint-free, if they are referring to something like not having cotton in them, it certainly will help from that point of view. But it really depends on how that pipe cleaner or brush is made. Are they holding the bristles in? If they are not, those bristles can end up inside an endoscope or any small routing, tunneling apparatus, which would leave the bristles there, and then they would end outside the body. So now we're worried about bristles, and again, it's something the body can't digest, or enzymes can't digest from the white cells, so you're going to end up with granulomas and then adhesions trying to stop that granuloma from spreading throughout the body. You turn around and really check that to make sure that those bristles are properly bound to the base of the brush, then you're going to be in much better shape or much safer. There's so many things to consider, unfortunately.
We've heard you talk a couple of times about granulomas and adhesions, and I'm not from a microbiology background, or I'm like many sterile processing people. I have actually no medical training whatsoever, and I hear from my time in the OR, I hear the techs or the surgeon talk about the complications that adhesions cause. Are adhesions predominantly caused by foreign particulates getting walled off, or are there just a million causes and it could be anything?
There are a lot of causes, and any time that you do a surgery and you have trauma to the tissues, you're going to have some adhesions. Now, most of those are going to, they'll hurt for a week or a few weeks, but they will tend to dissolve themselves. The fibrin dissolves within 2 to 3 weeks. It's those that stay around, something is keeping them there. And that's when you end up with the particles or the lint that could be present, and it forms a granuloma. So the white cells have attacked it. They've tried to get rid of it. They were unsuccessful. They mount up, and now you have a granuloma, which is a little ball of dead white blood cells and fibrin that's trying to wall this invader off. And then the body starts taking the fibrin and it shoots it off it's got to stabilize it. It doesn't want that to get anywhere. So you get the spider web, if you will, of fibrin. And that can since it's not able to get rid of it or dissolve that particle, it stays there. And what does fibrin do in the wound? Remember how it pulled the wound together? Well, in an adhesion, it will also contract. And if it's around an intestine, maybe that's where it formed its anchor, then you can have an obstructed bowel. One individual ended up with that occurring. The fibrin contracted, and it was actually around the blood supply to her kidney. And for a simple operation, she ended up having, unfortunately, after these adhesions at work caused by particles, and that strangulation occurred, she lost her kidney, had to be removed the next month. So these adhesions can be very, very serious. If you had the obstruction we were talking about, 10% of the time when you go in to stop an obstruction caused by adhesions, unfortunately, it has a death rate of 10%. Or if it's in the fallopian tube, you can have an ectopic pregnancy, or you could lose the ability for at least the ovary in that fallopian area to be able to have eggs enter. So there are just many cases where adhesions can be very serious if there's something that is keeping that adhesion present, such as lint particulates.
It sounds like from what you're saying that not just how much foreign body material ends up in the body, whether it's organic or non-organic, that location has a big factor on what the complications would be as well?
Very much so. Both the location as well as the composition, so whatever chemical it may be. For instance, the person I was talking about that had the kidney issue, she was actually sensitized to some of the chemicals that were coming off those particular particles. So it's the chemical composition and the position, and then in addition to that would be its physical characteristics. If it was asbestos, for instance, or something like that, or something that was very sharp on ends, then you'll have even a stronger reaction because the body sees as a larger threat.
Well, then we go back to the brush bristles, and you've got me thinking about that a decent amount. And I've always known, just with a background in nursing, that no matter whether it's organic and we'll talk about this in segment 2, the concept of sterile dirt that gets presented, to me many times when I've done education for the OR staff. And what I would say is that you eloquently described how the body, in a very easy to understand way, how the body is gonna, of course, the immune system is gonna react to that and it's gonna want to try to get rid of it. But as it relates to adhesions, it's that foreign body that allows those complications to, instead of be eradicated, linger, and that's where they cause problems. And I think you really made it easy for people to understand why that is so serious. And leaping off of that, we even think about surgical towels, and obviously lint-free towels is a big move, but you said earlier that, lint-free entirely isn't necessarily reasonable, but maybe significant reductions in lint. How do you think sterile processing managers should think about and evaluate practices in their facilities around surgical towels, or are there alternatives as well?
Yes, and that's a very good topic. We had a question once. They were having some problems, the surgeons were, in having some blue lint. Couldn't figure out where it was coming from, dark blue. And it turned out that in sterile processing, they were using a terry cloth towel for drying things. And similarly, in another hospital, they were having problems with some lint, and it turned out that in the assembly area of the sterile processing area, they took a white towel, or a white low linting towel, and just went over that assembly area where you're actually putting the devices back together again, and they found a large amount of lint, and that was both cases. We found that they were able to correct those problems once they identified them. It is a very serious condition, and just going through to see where are they putting their clothing when they put up a sweater or a fleecy sweatshirt. Is that in an area that's put away from where it might contaminate the area as well? There are just several things to look at. Of course, never dry brushing with a broom. You wouldn't want to bring everything up. You want to wet mop or wet vacuum whenever possible. there are some nice little ways to look to see where there might be problems. If you will take some material that you're using in sterile processing or in the operating room and just rub it several times and then turn it 90 degrees and rub it again several times as if you were rubbing against the table or trying to rub something off of a device, and then put it down and take very, very, very clear wrapping tape to use in packaging, any of the very, very clear Scott or 3M or any of those that make them for packaging tape, and put it down and put your hand on that place that you rubbed it and smooth it out with the side of your hand, and then pull it up and then turn it 90 degrees again, because the nap could be either direction, and put it down again, do the same thing, pick it up, and then put it on a jewel case, clear. Then you can see the lint that's produced. You'll see the color, you'll see how much is produced, and you'll start to understand what things need to be changed. That's probably one of the easiest ways. Another way is when they change your HEPA filters, please ask the engineer to save that for you so you can see it at home. If you can see the filters from your heating or air cooling devices, and you can see how them get dark or they have different colors. That will help you to see what color of wipe or a gown or drape or hat is causing a lot of the linting problems. Also making sure that underneath devices that you just don't want to move those things out of the operating room or to the side. Underneath the dust bunnies, and that will give you a clue of some of the colors and textures of some of the particles that are swimming around in the room.
That was Dr. Wava Truscott of Truscott MedSci Associates, LLC. And guys, I always have heard about adhesions, and I had a general understanding of what they were, but I definitely never understood what types of post-operative complications and how those post-operative complications would come into play. And Wava really outlined that well. I didn't even realize it was as serious as she informed us in today's episode.
That's right, Justin. And a lot of focus is put on the topic of bioburden. That seems to be, if it's not IFUs, the key word in our industry is bioburden. But today, just focusing in on lint and the impact that can have on the patient and the wound healing in particular. I mean, huge educational opportunity, not only in this particular episode, but I think an encouragement to really get out there and study some of those references and studies that she referenced, where folks have really put in a lot of time and effort to zero in on this particular danger in the continuum of patient care, and in particular in the impact that our processes can have, not only on bioburden again, but on these other infiltrations, if you will, into this process. So I hope folks walk away from this episode, as I do, with a bit of surprise, but then also some encouragement, to get out there to research more about these particular dangers.
Yeah, really, Hank, we do. We throw the word bioburden around, but truly it's bigger than that. It's any foreign body. So looking forward to the second segment, which will be released in a future episode, but that one will be talking about sterile dirt and endotoxins. So be on the lookout for that episode. That's going to do it for this week's show. As a reminder, you can help support us by subscribing to Beyond Clean on iTunes or Stitcher, and now also Google Play and Spotify. Simply search for Beyond Clean Podcast. We'd certainly appreciate a rating and a review. Your feedback is important to the show, and if you do have any topics that you'd like us to cover on a future episode, or if you'd like to share a picture anonymously on our Instagram page, just send an email to info@beyondclean.net. On behalf of Hank, Mike, and myself, thank you for listening to another edition of Beyond Clean.